Thank you for the opportunity to be back here in Beijing. I'm going to be starting off with a basic review from the US perspective of the Watchman device, an exciting device for the prevention of thromboembolic stroke and atrial fibrillation. Before I start, I'd like to remind everybody that at 12:30 today, at room 302 here on the level 3, there will be an advanced hour-long symposium covering the Watchman device by Dr. Saibal Kar from Cedars-Sinai and the Honorary President Yaling Han. They will both be moderating that session. So if you want an in-depth dive into the Watchman, 12:30 room 302A. I apologize as well that the Chinese slides do not appear to be up. So what are the current guidelines for Watchman in 2016 or 2017? The European Society of Cardiology has a Class 2B level of evidence B recommendation that left atrial appendage occlusion may be considered for stroke prevention in patients with atrial fibrillation and contraindications for long-term anticoagulation. On the US side, there are no current ACC or AHA guidelines. We have yet to catch up and decide what it is that we will be recommending. The potential global appropriate rationales, though, are very obvious. The first is recurrent bleeding with long-term oral anticoagulation with the ability to take short-term oral anticoagulation. The second is a high risk of bleeding from frequent falls and frailty for patients who have not bled. The third is non-adherence or refusal to take oral anticoagulation long-term. And the fourth is recurrent thromboembolic stroke on therapeutic oral anticoagulation with other etiologies ruled out. The FDA approved the Watchman device in 2015 in the United States, but the problem with the approval was that they followed the original trial recommendations and stated that patients had to be eligible for warfarin, which does not really make sense. The US Center for Medicare Services, which is the body that pays for the device, then stepped forward in 2016 and modified that initial recommendation. They stated that the patients had to have a high CHADS-2 VAS score. There had to be documentation by independent non-interventional physicians or shared agreement. The patient had to be suitable for short-term warfarin, but unable to take long-term, so they are not covering it in patients who are unable to take oral anticoagulation at all, and that the procedure had to be performed in established structural heart or EP programs by people who have been well-trained in the procedure. And the patients who were enrolled had to be in a national registry to track their outcomes for at least 4 years. And once again, this differed significantly from the March 2015 FDA approval. Just a few slides about pre-procedure planning for those of you who have not yet started Watchman. I understand in China that 3,000 Watchmans have been implanted to date. TEE must be used. You must perform a full sweep of the left atrial appendage during the procedure. You measure your ostial and depth of appendage at multiple angles for sizing. The ostium measurement is from the left circumflex inferiorly to the lateral ridge superiorly, and the depth from the plane is perpendicular to the LAA ostium. If the left atrial size pressure is low, consider giving a fluid bolus to ensure that the left atrial appendage expands to its maximum size, given that most patients tend to be fasting. If you would like for pre-procedure planning, cardiac CT is actually more accurate and results in less device use per implant. You have 1.25 versus 1.8 devices in the paper by Jacqueline Saw. Morphological limitations of left atrial appendage. A Watchman cannot be placed if the depth is shallow, less than 17 millimeters, if your ostial diameter is larger than 30 millimeters, if you have a chicken wing left atrial appendage morphology with a proximal sharp bend, or if you have multiple proximal pockets. Your sizes are your 21, 24, 27, 30, and 33, and the device should be oversized by about 20% of the appendage. These are the different left atrial appendage morphologies. You have the cauliflower, you have the windsock, the broccoli, and the chicken wing. And the chicken wing is the one, because of its shallow angle in this plane, that you may have difficulty implanting the device. From procedural detail standpoint, we have femoral venous access with figure of 8 sutures for bleeding control, or pre-closure, and you place a 14 French sheath. You must be well-versed in transeptal puncture, and it's an inferior-posterior position of the puncture so that you can aim upwards towards the left atrial appendage. determine your left atrial pressure size, and if it's less than 12 millimeters, give an IV bolus to overcome the undersizing. Obviously ensure meticulous anticoagulation and bubble control technique. The sheath is then advanced over a stiff wire placed in the left superior pulmonary vein. You then place a 6-French pigtail, which engages the left atrial appendage under imaging guidance, and you perform left atrial angiography. Both the sheath and the pigtail are then pushed together over, which is crucial that you have the pigtail out there because it minimizes perforation of the left atrial appendage. The device should be oversized. The device is then slowly unsheathed. If it's too distal, you can partially recapture the device. If it's too proximal, you have to completely recapture the device. And then you check for coverage. You perform a little tug test, and you have make sure there's an adequate seal, and there should be a less than 5 millimeter leak by TEE. Here is the device. These are the various sizings and the corresponding left atrial ostium, so you can see the slight oversizing, the catheter. Here there are markers for the different size device for the same sheath, and you can see upon engagement here, once you enter the left atrial appendage, you deploy the device, and the TEE is performed to check for leakage. This is very important, the pharmacotherapy. After the Watchman, and some would argue that it is almost as important to ensure the success of the procedure itself. You take lifetime aspirin between 81 to 325 milligrams for all patients. For the patients who can take it for a short period of warfarin, use warfarin to an INR of 2.3 to 3.0 for 45 days. Then clopidogrel 75 milligrams daily for 6 months. Some acceptable alternatives are post-implant NOAC instead of warfarin, or no warfarin or no NOAC in very high bleed risk patients with or without clopidogrel. There's quite a bit of data for aspirin monotherapy with acceptable outcomes. Just very briefly to review the PROTECT AF trial, this was the initial proof of concept trial enrolling patients from February 2005 to June 2008, published in the Lancet in 2009. There was no chance requirement, and that was a significant problem with this trial. There were 2-to-1 randomization of 707 patients to determine device non-inferiority or efficacy. And then, as you can see, the control group was maintained on warfarin therapy for 45 days, and if there was a leak, they were treated 6 months. So they did check the patients for leak at 3 months to make sure that they could stop warfarin. Implant success was 91%, and the mean follow-up was 18 months. The major problem with this trial, it was that there was serious pericardial effusion and major bleeding in a large proportion of patients. In the long run, the control group suffered from hemorrhagic stroke, so the balance of an upfront risk of pericardial effusion and tamponade versus the long-term risk of hemorrhagic stroke was present. The device showed composite efficacy was slightly lower than warfarin therapy, but safety overall was worse with the Watchman because specifically of the pericardial effusions. So the question then arose, could we overcome the safety issues by ensuring with more experienced operators? And this led to the PROTECT AF Continued Access Protocol Registry, or the CAP registry. And you can see here that in the beginning, if you simply looked at the very early experience, we were able to overcome that later with more experienced operators. We did not have as much bleeding. Most of the events accrued up front. And here is the data reported from the CAP and PROTECT registry combined. Overall, you can see that the procedure time fell and the serious pericardial effusion rate fell as well. The PREVAIL trial was then designed because the FDA did not approve the device based on PROTECT data, and this used a higher risk group of patients to neutralize the learning curve and of the early experience of PROTECT AF. This was randomized 2-to-1 and was multi-center, and they looked at patients with CHAS-2 scores of greater than 2. And here the protocol for anticoagulation was different. There was Watchman occlusion of 45 days of warfarin or 6 months in non-seal at 3 months versus chronic warfarin. They had 407 patients. Here is the event-free Kaplan-Meier curves. Only 6 early events occurred in the device group, 2.2%, Once these were accounted for, comparing events at greater than 7 days post-implantation, the rate of stroke was greater than 7 days after randomization for the device, and 0.020, so less than 2% for the control group. So both very low rates of stroke. Non-inferiority of late outcomes was achieved. This then led on to the ASAP study, which is a multi-center prospective non-randomized study, because they were curious to know what happened when you got rid of warfarin altogether. And here you had 150 patients who were not candidates for warfarin. The mean follow-up was 14.4 months, and it was very acceptable ischemic stroke rate. These are patients who are only on aspirin with a high CHADS-2 VAS score of 4.4 of 1.7% per year, with a very low hemorrhagic stroke rate. And the rate was less than expected of their equivalent CHADS-2 scores of 2.8, so there was a 6% drop. So at this point, the next step is ASAP-2, which is now going to be a randomized control trial addressing this exact question. It has just been, the trial design has just been published in the American Heart Journal in 2017, and enrollment will commence soon with a goal of 888 patients from 100 global sites. I'm sure China will be included for 60-month follow-up. The post-FDA approval US experience thus far, for a year from 2015 to 2016, there were 3,822 patients in 169 centers. There was 96% successful implantation, low rates of pericardial tamponade, low rates of device embolization. So overall, building on all the lessons we learned from the first two trials, we have successfully began a rollout in the United States. And at this point, there have been in excess of 5,000, 6,000, 7,000 patients enrolled. So to summarize, left atrial occlusion with Watchman device implanted with the appropriate training is safe, even for new beginners who are adequately proctored. Number two, the best data is for patients who can take short-term warfarin. Number three, there is reasonable registry data for patients who cannot take long-term or even short-term anticoagulation, and a randomized trial, ASAP-2, is currently pending. The cost is significant given the burden of atrial fibrillation, and cost efficacy will ultimately decide widespread long-term use. Thank you very much.